Today, we're diving into ventricular arrhythmias, rhythms that start in the ventricles rather than the atria or the AV node. Because the ventricles are the last stop in the heart's conduction system, disturbances that arise here are often serious, sometimes fatal, and always demand close attention. These arrhythmias include premature ventricular complexes, ventricular tachycardia, ventricular fibrillation, idioventricular rhythms, and asystole. In this lecture, we'll focus on the first three: PVCs, VT, and VF. A premature ventricular complex, or PVC, is an extra beat that originates in a ventricle and jumps ahead of the normal sinus impulse. PVCs are common and can occur in healthy people, often after caffeine, nicotine, or alcohol. They can also be triggered by more serious issues such as ischemia, myocardial infarction, heart failure, hypoxia, acidosis, or electrolyte disturbances like hypokalemia. On the ECG, a PVC is easy to spot. The QRS complex is wide, bizarre in shape, and lasts at least 0.12 seconds. When they all look the same, we call them unifocal. When they look different from one another, they are multifocal. They can also fall into patterns. Every other beat is a PVC, known as bigeminy. Every third beat is trigeminy, and every fourth beat is quadrigeminy. Patients sometimes describe PVCs as the heart skipping a beat, though many feel nothing at all. The impact depends on when the PVC occurs in the cardiac cycle and how much blood the ventricles had time to fill with. Treatment focuses on correcting the cause. Long-term drug therapy is usually unnecessary, but if PVCs are frequent and persistent, amiodarone or beta blockers can be used. More importantly, frequent PVCs should prompt an evaluation for underlying ischemic disease or ventricular dysfunction. Ventricular tachycardia, or VT, is defined as 3 or more PVCs in a row at a rate greater than 100 beats per minute. The causes are similar to those of PVCs, but patients with large myocardial infarctions or reduced ejection fractions are at higher risk for lethal VT. This is a medical emergency because patients are often unresponsive and pulseless. On the ECG, VT appears as wide, abnormal QRS complexes, regular but very fast, usually between 100 and 200 beats per minute. P waves are usually difficult to identify, and the PR interval is irregular if it can be seen at all. The patient's tolerance depends on their heart function and the ventricular rate. Some may be stable for a short while, but most deteriorate quickly. Management depends on the type of VT and the patient's condition. If the patient is stable, further assessment and a 12-lead ECG are appropriate. Antiarrhythmic medications, such as procainamide, amiodarone, sotalol, or lidocaine, may be used. If the patient is symptomatic with monomorphic VT, cardioversion is the treatment of choice. If the patient is pulseless, defibrillation is required immediately, the same approach used for ventricular fibrillation. Long-term, patients with an ejection fraction less than 35% should be considered for an implantable cardioverter defibrillator. Patients with better function may be managed with medication. A particular form of polymorphic VT is torsades de pointes, which is usually preceded by a prolonged QT interval. On the ECG, the QRS complexes twist around the baseline. Causes include congenital QT prolongation, electrolyte imbalances such as low potassium, calcium, or magnesium, central nervous system disease, and a number of medications including ciprofloxacin, erythromycin, haloperidol, lithium, and methadone. Torsades is unstable and can quickly progress to pulseless VT or VF. Immediate treatment is required, including correcting electrolytes, administering IV magnesium, and, if bradycardia is present, using isoproterenol or pacing. Ventricular fibrillation is the most common arrhythmia seen in cardiac arrest. It is a chaotic, disorganized rhythm in which the ventricles quiver instead of contracting. As a result, no blood is pumped. VF is most often caused by coronary artery disease and acute myocardial infarction, but it can also result from untreated VT, cardiomyopathy, valvular heart disease, electrolyte disturbances, electrical shock, or certain medications. A condition known as Brugada syndrome, more common in patients of Asian descent, can also predispose otherwise healthy hearts to VF. On the ECG, VF shows up as irregular, undulating waves with no recognizable QRS complexes. The ventricular rate is extremely rapid, greater than 300 beats per minute, but the rhythm is completely disorganized. Clinically, the patient will have no pulse, no heartbeat, and no respirations. Death is imminent if immediate action is not taken. The treatment is straightforward but urgent. Start CPR immediately and deliver defibrillation as soon as possible. Early defibrillation is the key to survival. If VF persists despite shocks, medications such as amiodarone and epinephrine may help achieve return of spontaneous circulation. Ventricular arrhythmias range from nuisance PVCs to deadly ventricular fibrillation. Recognizing their ECG features, understanding their causes, and acting quickly with appropriate treatment is life-saving. Always remember, when you see a rhythm that originates in the ventricles, it's never something to brush off.